Hello and welcome to Doc Talk Live. This is NorthBay Healthcare's way to reach out to the community on important health issues. Today we are talking with urologist Herk Khaira from NorthBay. He's going to talk about when you gotta go, when you can't go, when it hurts to go. So take it away, Dr. Khaira.
Thank you. So today's talk is going to be somewhat of a urologic hodgepodge. I thought it would be a nice opportunity for those that are interested to get a little bit of information about a lot of different problems and the normal anatomy of the urinary system. You have the capacity to ask questions, and the one thing that we lose sometimes in the Facebook Live talks is the capacity to just kind of raise your hand or kind of indicate that you're interested in asking a question. But please, if you have any questions or anything, any burning issues, just feel free to submit that and we can address those at the end of the talk. So the urinary system, that's what the urologist deals with. And what is that specifically? Well, I tell patients it starts at the top of the kidneys, the adrenal glands in the kidneys, travels down the abdomen, the ureter tubes, which connect the kidneys to the bladder, and then the male and female reproductive organs are involved in this process. And notably, one of the biggest things a urologist deals with, the prostate. So I'd like to use this talk to talk first about the normal urinary function of the kidney and the bladder, and we'll also talk about the prostate. So getting started with the bladder. What exactly is the bladder? What's a healthy bladder? The bladder is an organ that sits in the lower abdomen in the midline. Everybody pretty much knows where their bladder is. It's just right above where they go pee. And what is the function of the bladder? The bladder is both a storage organ and an expulsive organ. So it's supposed to hold urine for us until it's time to go. And what's normal in that circumstance? Well, everybody's different. Sometimes I see a patient who says, ever since I was a kid, I've gotten up once or twice at night, and I go during the day every 1 or 2 hours. Well, that would translate into somebody going 12 times in a 24-hour period. That's a lot, and that, if it was something new, would be considered possibly a sign of a disease. But on the other hand, this patient who says it's been that way for their whole life, for decades and decades, that can be normal. In general, we say 8 voids in a 24-hour period on average is about the maximum of normal. And somebody who's going more than that, there's usually a reason to further investigate. On the other hand, sometimes I have patients who are like camels. You know, they hold their fluid for a long, long time, and sometimes just go once or twice during the day and not at all at night. And they've done this their entire life. This is not pathologic. This is just the function of the body. So there's extremes as to how often somebody will go to the bathroom. Well, what is the bladder doing? Well, taking a look at this imagery, hopefully you can see it. Mm-hmm. You can see the kidneys. These are the twinned organs in the back, up by the ribs. Way in the back, the ureter tubes that drain down, and there's the bladder. Well, this imagery shows a diseased organ, but nevertheless, the idea is just to show the distance between the kidneys, the ureter, and the bladder. Now, the kidneys are typically creating urine. They're filtering blood, and then urine drips down into that bladder. They're taking waste out of the blood and taking some fluid and passing that through. And that can range usually about 30 to 50 milliliters every hour. So if you calculate a milliliter, 30 milliliters is about an ounce. So 1 or 2 ounces of urine typically being made hourly with normal hydration for the average person. So when the bladder gets to a certain threshold, which is usually about 200 milliliters, 250 milliliters, that's when most adults would get some degree of urge to go to the bathroom. Now, we can forestall that through our conscious mind, saying, I want to hold my pee a little bit longer and not have any problems. But eventually, as that bladder starts filling up more and more, you get more kind of urge symptoms, and obviously most everybody's been in the situation where they really have to go and they can't wait any longer, and that's when the bladder has gotten really to capacity. At that point, typically we get to the bathroom, empty out our bladder, and move on. Usually we shouldn't wait until that point, but that sometimes happens with people. Now, what is pathology in this circumstance? Meaning, what is the disease process regarding bladder frequency? Well, number one is, let's say the bladder's taking over your life. Every hour or less, or every 2 hours, having a strong urge to go to the bathroom that cannot be forestalled. And in fact, trying to delay that, leading to leakage and loss of control of urine. Well, that's a problem. That's something that should get investigated. I have a lot of patients who tell me, well, I just thought this was, the old man or old woman's disease and I had to deal with it. And I always emphasize to my patients, no, that's not something that you have to live with or deal with. That's why God created urologists. These are things that we address and try to prevent or fix if they are happening. But another way to think about it is the bladder starting to fail in its primary function. It's supposed to hold that urine for the individual, and then when you want to go to the bathroom, when the person wants to go to the bathroom, it should be able to empty on demand. It should not be doing its own thing. It shouldn't decide, I'm full, I'm going to squeeze and empty. And usually when that's happening, it means there's some sort of disease process going on. And I'll talk about that a little bit when we talk about the prostate. So, when it comes to just normal good voiding hygiene, what are things that a person should be doing? Well, first off, probably not forestalling voids. If there is an urge to go, generally listening to the body and going to the bathroom. So I talked earlier, like if you have to go to the bathroom every hour or two, that's probably not normal, but doesn't mean you should avoid doing that. Trying to suppress that urge to go can further damage a bladder that might be dealing with an underlying problem. And a classic example is, let's say somebody has a big prostate and it's causing a blockage. The bladder is trying to force through that blockage and may only be able to get a little bit of urine through. If you don't listen to your bladder when it's trying to get rid of that urine and try to hold longer, well, then in turn, this obstructed bladder can start backing up more and more with urine. And then we can get secondary problems. And what are those problems? Well, that back pressure in the bladder can lead to back pressure in the kidneys. And remember, I talked earlier that the kidneys are filtering blood, getting rid of waste and fluid, and sending it down, not with very minimal pressure, down to the bladder. But when you have a high pressure bladder or a very full bladder that's not emptying, or maybe someone feels like I need to hold it more, that pressure gets transmitted up to the kidneys. And those kidneys are not well equipped to deal with that obstruction and that pressure. So what ends up happening? Well, those kidneys stop filtering as much blood. They start saying, well, I have nowhere to send all this waste and fluid, so they stop filtering blood, and in turn, waste levels in the body can increase, and those kidneys can subsequently get damaged. What are other things that can happen from an incomplete emptying bladder or bad bladder hygiene? Well, that stagnant urine can be a source of a lot of problems. I tell my patients, think about it like a river versus a pond. We always hear, oh, urine is sterile, don't worry about it. Well, that means that there's no infection in there typically. And that means that's tied to the kidneys filtering the blood, making the urine, it promptly passing down to the bladder, and then evacuating from the body. So that's like a river just flowing out. Now, on the other hand, remember I talked about bladders that aren't emptying or obstructed. Well, think of that as a pond where there can be just debris and algae and whatnot accumulating. That can be a source of infection, and that infection can be pretty dangerous if we can't get the bladder to empty, or if it starts transmitting to the rest of the body, going up towards the kidneys or getting into the bloodstream. And these are the circumstances where people can get urine infections that cause sepsis, cause horrible problems, kidney infections, pyelonephritis, and these are things that we obviously want to avoid. So, continuing on like good bladder hygiene, I was talking about first off, making sure to go when the urge is there. And if there is a lot of urge and frequency or leakage, that needs to get investigated. talk to your primary care doctor, let them know what's going on. And oftentimes there can be remedies for this, or at least the start of a process to find out what's going on with the bladder. In terms of good bladder hygiene, in addition to trying to empty when the urge is there, also not straining. This is something that's hard for people to fully grasp, but our body is designed so that the bladder should work independently from all the other muscles. So if we go to the toilet and we start straining our tummy muscles, like contracting, squeezing really hard to push things out, we're actually fighting ourselves. And here's the reason why. All that pushing on the bladder from outside is also going to push on the muscle that keeps us dry. So we end up having this circumstance where we're fighting ourselves. And the end result is we get muscle spasms, we get damage to that bladder, and the overall function of the bladder starts deteriorating. Classic behavior of the bladder should be, it should be silent until we get that urge to pee. When we go to pee, the muscle that keeps us dry, we call it the urinary sphincter, should relax while the bladder muscle squeezes. But if we start trying to beat that system with our conscious mind and using other muscles, because when we're squeezing those other muscles, we're not squeezing the bladder muscle, we're squeezing things around it. Well, we're putting more pressure on both sides, and you may get a better jet of stream, but the natural function of the bladder can be compromised. And chronically, if people are doing this, you start seeing other problems, like the bladder stops emptying. That muscle that's supposed to relax doesn't relax as well. And we can get the whole litany of problems, including incomplete emptying of the bladder, infections, and that stagnant old urine can be associated with getting stones and other problems in the urinary system. So that's another aspect of good bladder hygiene, not straining. Then in terms of recurrent urinary infections or an individual that's getting infections, for men, it's one thing. A man who's getting a urinary infection, it usually represents something going on inside the body. I tell patients, bacteria, they don't have legs. They don't climb from outside the body all the way up the male urethra, past all these blockages, and then into the bladder and cause an infection. It just typically doesn't happen that way. In general, for a man who gets an infection, there's some sort of fertile ground in the bladder that's leading to that infection. It could be a foreign body, like a stone or some kind of pocket in the bladder where stagnant urine is sitting. It could be obstruction from the prostate or stagnant urine in the bladder that's built up and it's just never emptying. Liken it to a toilet that never flushes completely. Eventually, it's going to get kind of yucky in there. So that's number one. A man who gets a urine infection, that needs to get fully investigated. A man who ever tells me, oh, I had an infection in the past, I said, well, what'd you do about it? That should have been checked out right away. And if it hasn't, that's another reason to see your primary care doctor. Now, women, on the other hand, there is a much shorter urethra. And so bacteria from the outside world can get in through the urethra and lead to infections. Classic examples of this can be after sexual intercourse or from just wiping errors. And so, as everyone's taught, wipe front to back and then discard that toilet paper. After sexual activity, promptly emptying the bladder and not holding the urine, because if that bacteria did get pushed into the bladder during the sexual activity, then we want to flush it out. We don't want it to sit there and just grow overnight and then be a source of infections. And beyond that, if there are a lot of recurrent infections, in the order of 3 or more in a 6-month period, that needs to get investigated, and again, talking to your doctor about that. Or if there's what we call complicated infections, infections where you get really sick, end up with fevers or kidney infections, these can represent underlying conditions that need to get investigated. And if not investigated, this could risk, again, those things I talked about, like sepsis and kidney infections that can put people in the hospital. All preventative things if caught early. And then lastly, in regards to things that go on with the bladder that I always tell my patients, well, that probably should have gotten checked out, is blood in the urine. So anytime somebody sees blood in the urine, if we don't have a good explanation for it, like, oh, I had an infection or I passed a kidney stone and the blood in the urine was directly related to that event, blood in the urine should get promptly investigated. And this means going to your primary care doctor, and usually in the course of the workup subsequently with the urologist, specialized urine testing is done. Typically a little scope is used to look inside the bladder, and usually some sort of imaging of the upper systems of the kidney and the tubes that connect the kidney to the bladder, the ureters. And this is all pretty straightforward testing, pretty easy to do. That scope test I described can oftentimes be done in the office setting with minimal discomfort. So again, if this ever afflicts you, blood in the urine, something to tell your primary care doctor about. So that takes us on at this point to the prostate. And the prostate can be a source of just so much discussion. I'll try to be succinct and try to hit some of the basic points. First off, what is the prostate? So again, here's a good image of the prostate. This is the bladder. This is a side section. The prostate sits right beneath the bladder. It's an organ that is only within men. And the urethra tube, the urinary tube, travels right through the middle of the prostate before going in through the middle of the penis and then emptying urine into the outside world. What is the prostate's function? What does it do? Well, it creates a fluid that's involved in fertility. So when a man is beyond the years that he's interested in fertility, the prostate doesn't have much functional benefit. On the other hand, it's interesting that as a man approaches those years into his 40s and 50s, that's when we start seeing problems really develop with the prostate. Very strangely, it becomes this organ that's more trouble than anything else. And what are the three problems that we typically see in males that are older with regarding the prostate? First is infection. We call that prostatitis, and that can manifest in irritable voiding symptoms, burning, urgency, frequency, positive urine cultures, and the need for antibiotics. Pretty obvious stuff when you have it, and stuff that should get checked out by your doctor. The other two problems, very common, are prostate cancer and enlargement of the prostate. And as I said, as men get older, past their 40s and 50s, we see that the prostate, for some strange reason, just continues to grow. And in general, this can be associated with bothersome urinary symptoms. And those bothersome urinary symptoms can be both obstructive and irritative. So obstructive means by constricting the urinary stream, a man has a harder time emptying his bladder. He has to sometimes spend more time to empty his bladder. He may not empty it entirely and have to go to the bathroom more frequently and get up at night. And that enlarged prostate can also lead the bladder to go into dysfunction and get very muscular. And that is classically where we see these irritative voiding symptoms. So here is a good example of a normal cystoscopic appearance of the bladder. And by that I mean if a urologist puts a scope in the bladder, we oftentimes see in a good healthy bladder a nice smooth skin. Well, if the prostate is obstructive or there's some other obstructive process, we oftentimes start seeing these occur. And these are called trabeculations. And they're deposition of smooth muscle and collagen within the wall of the bladder. And if that obstructive process persists and gets worse, we see the trabeculations can oftentimes get worse and thicker and more rigid. Well, getting back to what we talked about way in the beginning about the bladder, what would one think would be the consequence of having more muscle and thick collagen? And what's collagen? It's a precursor to bone. It's the stuff that's in our ears and our nose. It's less compliant, less stretchy tissue. It's stronger and more rigid, and it can be helpful in the process of trying to keep the bladder intact and maybe even empty, but it won't hold as much. And it won't stretch, and it's sort of like just a tighter organ. So now as the kidney sends that urine down to the bladder may distend, but this non-stretchy trabeculations won't give. And as the pressure goes up, that's when the bladder signal and to the brain gets more urgent. Gotta go, can't hold much more. And where if it's really bad, the bladder can act autoreflexively, meaning kind of like the way you think about a doctor who taps the hammer on the knee and you get the automatic kick. Well, the bladder can do that. If the pressure gets high enough, it can send a signal to itself, which is basically just auto-reflexively squeezing and emptying out that urine. And that can manifest in leakage against your will, maybe trying to get to the bathroom on time but not be able to get there. Garage door opening as you're coming home and all of a sudden your bladder squeezes and you get that leak. Well, these are all representative that maybe the bladder is struggling and having a hard time, classically with obstruction. And getting back to the prostate, I was talking about the obstructive symptoms and irritative symptoms. And so those irritative symptoms from an obstructed, very coarse bladder could include frequency, getting up at night, losing control of urine, getting a lot of urge to go to the bathroom but then not able to empty, and then double voiding, going a little bit, stopping, going a little bit. And these are all kind of things that can be representative of that enlarged prostate problem. What can be done about that? Numerous things, and probably for the scope of this talk, a bit too much to get into, but basically we have pharmacological therapies that are commonly used. These are pills that can be used to shrink the prostate or relax it or get better blood flow to the prostate. There are procedures that can be done to open the channel of the prostate. And then classically, there have been surgeries for those really big prostates that are not amenable to other therapies, and that can be to remove the prostate. The last condition that I was talking about the prostate was cancer. And what is prostate cancer? What's the significance of it? Well, first off, there's a lot of concern and discussion about how much prostate cancer should we be investigating? Should it all be caught? Should it all be treated? In our current society, prostate cancer remains the second leading cause of cancer death for men in America. And that's with all the investigations that we are doing right now. On the other hand, as a man gets older, and if he lives long enough, he will most likely get prostate cancer. And that patient population, the older population that gets cancer, most likely will live with the cancer, not die of it. So it becomes this somewhat conundrum. We have a disease that we know is dangerous and can kill men and cause a lot of what we call morbidity or side effects, but we also know that disease can be asymptomatic and not need investigation. What are we to do in this dilemma? Well, first off, the population that is most at risk of having problems with prostate cancer should get investigated. And so if it's a person who has a first-degree relative under the age of 60 who had prostate cancer, like a dad or a brother, that population usually should get investigated in their 40s, at least come in some point in their 40s for their first PSA test, which is a blood test, and visit with a doctor. If everything looks good, less frequent follow-ups are necessary every few years or so. For the general population, between the ages of 50 and 55 is a good time for a man to come in and get evaluated for prostate cancer. This is usually a baseline test. What that means, just finding out where the blood test, the PSA, sits, and also if there's any abnormalities on the prostate exam. And what is the prostate exam? It's something that almost all patients fear so much, and they tell me every time they come to see me how they've been dreading seeing me because of this. But in general, it's a pretty easy test for us to do. It is an examination of taking one finger and putting it into the rectum about this far to feel the outside part of the prostate. And we call that outside part the peripheral zone. That's the place where most prostate cancers develop. And what are we looking for? Well, when a urologist does that exam, he's looking for nodularity, anything that's suspicious for cancer, asymmetry, and also getting a general idea about the size of the prostate. And based on those findings, a decision whether any other investigation is necessary for prostate cancer. Now, used to be with the PSA test, it was a kind of a single threshold. Above this, further investigation, versus below this, everything's fine. We've come to recognize that things are a little bit more nuanced And in the last 10, 20 years, we've been much more judicious with our use of further investigations purely based on the PSA result. So, in the event that somebody has an isolated, elevated PSA test, that the blood test number has gone up, does not necessarily mean there's prostate cancer, but it warrants at least looking into it further. And as a urologist, these are things that we do, including that prostate exam. We have other blood tests, we have x-rays and different types of imaging that can be used in this circumstance to see, is there a good risk of prostate cancer? And if so, should we do further investigations such as a prostate biopsy? And in the event that a prostate biopsy is recommended, this remains an office-based procedure, with minimal discomfort, a small amount of bleeding afterwards. It takes about 10 or 15 minutes, and no need for pain medicine afterwards. So I always want to emphasize to patients, as much as we're trying to avoid biopsy, it is not that most terrible thing that you could imagine. And it's pretty well tolerated. Most people say it's much easier than they thought it would be. And from that point, once we do a prostate biopsy, we get tissue. That tissue is investigated for prostate cancer by a pathologist. And the next question that I always get for patients is, if there's cancer, what are we going to do? And that is really contingent on how much cancer and what is the grade or aggressiveness of this cancer. And again, that is determined with the pathologist, and then based on those results, we see that there's a whole spectrum of options. Number one is the option for active surveillance. Active surveillance means following the cancer, monitoring it, but not necessarily using radical treatments unless there's aggressive qualities that have developed. And with active surveillance, many patients can be followed for years, and I have a few patients that have been followed for over a decade without the need for any radical therapies. Essentially, the cancer can remain quiescent, not do any of those aggressive things that we worry cancers can do. But this just needs continued follow-up. On the other hand, if the cancer is aggressive appearing, we have both surgical options and radiation treatment options. At NorthBay, we have the surgical robot that allows us to do a very, very delicate, minimally invasive surgery through very small incisions on the abdomen in order to remove the prostate and reconstruct the urinary system. Fantastic tool in the armamentarium of a urologist that allows us to do this minimally invasive surgery with very low morbidity side effects for patients and a quicker recovery. Generally 1 or 2 days in the hospital with that surgery. Radiation can also be used in the treatment of prostate cancer, both by implanting little radioactive seeds in the prostate as an outpatient procedure, or the use of radiation therapy externally, in which a patient comes in for about 7 weeks, 5 days a week, for about 10 minutes or so to have radiation delivered to the prostate. Well-tolerated therapy, all with very, very good success rates for the treatment of prostate cancer. Robin, was there a question?
There is. We have a question about the prostate evaluation you were talking about. Is that something that's done by your primary care physician or only by urologists?
So the general evaluation of the prostate should be just part of an annual checkup with your doctor. Like I said, if you're at high risk for prostate cancer, meaning family members with prostate cancer, or an African American background, then usually getting checked in your 40s, and for everybody else, usually in your 50s. Again, part of that annual exam with the doctor, including the use of that PSA test. I say it's usually going to be checked when your cholesterol and your blood sugars are being checked, as well as that prostate exam. And the value of that is the general doctors oftentimes doing some other testing when they do the digital rectal exam of the prostate that can be used for screening for colon cancer. So again, if there's something abnormal on that evaluation, there's a reason to come see a urologist, and or if the primary care doctor is not comfortable doing those evaluations, most urologists are happy to see those patients, particularly if there's high risk and concern for prostate cancer.
How common are urinary tract infections?
So again, in which population, the question about how common are infections, well, it's not uncommon for women, particularly postmenopausally, to get 1 or 2 urine infections a year, uncomplicated infections. No fevers, no kidney infections, prompt resolution with the use of antibiotics. In the event that there's more than those infections, that usually represents something that should get investigated or treated. On the other hand, men with no pre-existing urologic problem should never get a urinary infection. So that is a reason for investigation if a man gets a UTI, urine infection.
How do you know, speaking of kidneys and kidney pains and stuff, how do you know it's your kidney and not just like a backache or a muscle strain?
That's a great question. And if we feel something under our ribs and our back, you usually say, oh, it's my kidney hurting, it's my kidney hurting. And sometimes you don't know it's your kidney hurting, on the other hand, and you think it's just a muscle ache. Well, the classic thing is the pain associated with the kidney is usually ipsilateral and unilateral. And what that means is on the side that there's a problem, you'd have the pain, and usually just on that side. So classically, if you reach back and you say, oh, my back's hurting, and you go up and down, that's probably muscular or something to do with a disc or a nerve. But if it's classically, I don't know if you can see me pointing it right here. It's okay. Yeah. But it's right under the ribs on the backside, and it migrates down towards the bladder. That sounds like a kidney pain. And the classic example I say is a kidney stone, where anywhere along the urinary system you might get pain. Now, a kidney stone can be a little tiny fella that is just, something on the order of a few millimeters that's traveled down the ureter tube. Can you see that,
yes.
Robin?
Mm-hmm.
And someone gets the most horrific back pain on that side. Well, why is that? Because, as I said before, the kidney's job is just to filter blood and urine and send that filter blood and create urine, and that urine is being sent down, and suddenly it's blocked off by that stone. This little tiny pebble has blocked the tube, and the kidney swells up like a balloon with that urine. It doesn't know what to do, and on top of that, that can be horrendously painful. Some people liken it to the worst pain imaginable, worse than natural childbirth. I've heard from some patients too. And so that would be one side, and that pain could travel all the way down towards the bladder. Sometimes for men, they can even feel it in the testicle on that side. And so they oftentimes feel like, oh, the stone must be way up here because I'm hurting so much. But it could be this far away from the bladder, way down low, but the pressure is traveling up, and that's where the pain is felt.
Okay. This person is asking, an elderly friend continues to develop UTIs. What can be the cause for this happening, and why so frequently?
Sure. So
female friend.
Female friend. That was, so postmenopausally, we do see an event that takes place in the bacteria count within the female vagina, in which it goes up dramatically. And we postulate that the drop in estrogen in the body leads to less blood flow ultimately to the vaginal skin, the vaginal epithelium. And that good, healthy skin sometimes can be overrun with bacteria. And remember I said that bacteria can get into the female urethra and into the bladder. And well, if there's more bacteria in that area, more can get up into that urethra and be a source of infection. So barring other sorts of problems like blockage or incomplete emptying of the bladder, one of the main reasons that postmenopausal women get these infections is that bacterial overgrowth. And fortunately, there's a good treatment for that, and that's usually vaginal estrogen cream, which can be just manually inserted once a week or twice a week and help get that tissue healthier, drop the bacteria count, and it has been associated with reducing postmenopausal recurrent UTIs by 50%. It's not an overnight fix. It's not something that you take this cream, it kills all the bacteria. But by getting those tissues healthier over time, we see the incidence of infection drop dramatically.
Right. We're almost out of time, but I'm wondering, as a urologist, if there's one sort of universal piece of advice you have for people to keep their urinary tract system healthy and functioning well.
I was going to mention this earlier, and this is probably not a good piece of advice. It's actually the contrary advice. I get patients who are always asking me how much fluid they should drink. And I see the full gamut of people who have urinary problems. So let's think about this. I see patients with kidney stones. Kidney stones develop classically, number 1, number 2, and number 3 cause of kidney stones, chronic dehydration. So those individuals that are not drinking enough water or other fluids are having urine that's very concentrated, and items like calcium and oxalate and phosphate can come out of solution in the urine, bind together, create crystals, and then exponentially you get these little stones that can form. That population, I say, ideally, if you're making stones, we want you to make at least 2.5 liters of urine a day. So on an average day, about 8 to 10 glasses at least of water spaced out through the day. And that can easily be done if you eat 3 meals a day, have 3 8-ounce glasses of water, you've already hit your goal there. That's for that population. Now, on the other hand, I have patients who have bladder problems, overactive bladder, or remember that bladder I told you about that's really rigid, and even after they've gotten their prostate fixed, they're still going very frequently. And if they're adhering to this 2.5 liter rule of urine, they're going to be peeing every 20, 30 minutes, and that's just not reasonable. So we have this very nice thing called the thirst mechanism. And most of us, if it's intact, will tell us how much we need to drink. And so if you're thirsty, obviously you should be drinking. If you look at your urine and it's concentrated and very yellow or darker than that, that means you're not drinking enough fluid. But on the other hand, if your urine's looking fairly clear with just a light tinge to it, you're probably well hydrated, you're probably drinking enough. So that's one thing that, if I was going to give one piece of advice, would be in the absence of there being some disease process where you need to drink a lot of fluid, oftentimes tailor it to your body and what's going on with your frequency and urgency and getting up at night and whatnot.
Cut the salt too, right?
Salt is, in general, remember I said 1, 2, 3 cause of stones is dehydration. Number 4, 5, 6 is salt.
All right. Well, we're out of time. Thank you so much, Dr. Khaira, for taking time. We want to invite everybody to join us next time on June 17th when Dr. Shanna Snow, who's one of our OB-GYNs, will be talking about pregnancy and the COVID virus. So please join us on June 17th at what time? 5:30 p.m. So thank you, and thank you, Dr. Khaira.